let's move on now to the patient who does probably need treatment. And we'll start with the transplant ineligible patients. And I did ask a little earlier about frailty, but I want to come back to that because it's becoming a more talked about issue. I've heard people say we should do a formal frailty index on each of our patients. It certainly hasn't been my practice today. Sagar, what?
Yeah, we haven't routinely incorporated it into our practice, but I think the principles are things that we certainly do use, and you're right, I guess it's in the eye of the beholder. And if you're unsure, I think as Paul said earlier, then I think you presume that they're going to get better and that the frailty is a consequence of disease, and if they don't, you can always change your treatment approach.
Well, so let's say we have a patient and they're not terribly frail and we're going to treat them, but they're not of the transplant age. Jatin, what are your goals of therapy when you start treatment for that patient?
I think when you talk about making treatment decisions for patients, at any point, it's really going to be a balance between what the patient's objectives are and trying to meet those. And so I think that when you're talking about older patients, it's going to be important to have a combination that's safe and well tolerated. That's going to be the critical aspect there.
Safe and well tolerated means you're not going to treat for deep remission, you're going to be more worried about quality of life, or what?
No, I think you still want to be aggressive with options where I think we have more new options now that are well tolerated, and I think that's the key. So I don't think we need to be less intensive in our approach, but I think we just need to be thoughtful and nuanced in terms of dose reductions and dose modifications and more supportive care. But many of our therapies now I think are very well tolerated, in fact.
Let me very specifically ask each of you very quickly. I'm going to give you a case and ask you to respond how you would treat it, okay? Let's take an 80-year-old, pretty healthy. I'll take my mother, I'll just think of her. Out walking every day with the dog, pretty active, 80 years old, some mild comorbidities, nothing significant. What's your frontline therapy for that patient?
Dose attenuated RVD.
Standard risk, dose attenuated RVD.
Yeah, either that or RD, depending upon the eyeball test.
The frailty index by the Lonial eyeballs.
Yeah, that's right.
Yeah, but this is relatively healthy. You would RVD?
Modified RVD.
What do you mean by modified for those watching?
So either weekly dosing of the bortezomib and a lower dose of lenalidomide, lower dose of corticosteroids.
Yeah, exactly. And subcutaneous bortezomib as well is critical because that, in the RVD light regimen, as we affectionately call it, that's critical to reducing neurotoxicity.
What are the actual doses for people watching? What lenalidomide dose you use, for
use 15 milligrams, 3 weeks on, 1 week off of lenalidomide. The dexamethasone is partnered with the bortezomib on the day of it and the day after, and typically using a lower dose, particularly in patients over the age of 75. And we use subcutaneous bortezomib. Actually, on the weekly schedule, 1.3 is relatively well tolerated, but a low threshold for going to a milligram per meter
I just wanted
squared.
to add that for particularly elderly patients, it's really important to calculate creatinine clearance.
Yes.
You know, even though the
Why?
15, because as I'm sure our community oncologists know, serum creatinine may not, even a normal serum creatinine in a small elderly female may be correlated with significant
What
renal.
difference does that make to your treatment?
Because of the lenalidomide being cleared renally.
You think that's true? You think you really have to dose reduce lenalidomide?
I do.
I agree, yeah.
I think, and the label says that. So the point is the label is based on renal clearance, creatinine clearance, and if you don't take the trouble of calculating it, particularly in an older patient, I think you might run into more cytopenias.
Jatin, you didn't have a chance to respond.
So I think that's a great question. I think that it's a little bit different in terms of where we practice in academic centers, where I think that those patients may be a little bit more biased than the one that you described that's going to come in and drive into Houston or these academic centers versus what we see in the community where there may be less, I think, more older patients in that setting who may not be able to travel. And quite frankly, there's other issues that come into our older patients. They may not be able to come back and forth weekly for Velcade. They may not have the supportive care and the social support and caregivers to allow them to do that. So I think that we've got to keep those things in mind. The data supports RVD now, especially with a SWOG study.
Since you mention it, let's just talk about the SWOG study for a minute. So, and that's not RVD light, to be clear, but just Paul, describe the SWOG study to the audience.
Yeah, the SWOG study is a very important trial. It's almost 550, 600 patients strong, and it was a randomized comparison of classical RVD with the intravenous route used for bortezomib compared to RD. And basically it shows an impressive progression-free and overall survival benefit to the 3-drug platform compared to the 2. The toxicities are very actually well balanced with the exception of neuropathy, which is more of a challenge for the RVD as one might might expect. And I think the critical message there, as well as the use of intravenous bortezomib, was the choice at the time for this randomized trial, and I think that's very, very important. Sub-Q, you halve the rate of significant toxicity. So I think that's tremendously valuable to community oncologists going forward. But if I may, Keith, I think beyond RVD and beyond that, we now have other choices.
Let me come
You
to
can
that.
come back
I'm
to
going
it,
to
yeah.
come back to
Okay,
that.
good,
What
yeah.
I'm sitting here thinking is about
Yeah.
the first trial and how lenalidomide, low-dose dexamethasone, maybe even a year ago, everybody said that's how you should treat an elderly patient based on this trial, which showed this was superior to MPT and particularly when you use the lenalidomide for a long period of time, continuous therapy. Are there any patients left? Should everybody get RVD light, or should
I think it's important to distinguish between your initial question is what would you treat your 80-year-old mother with versus what would you do till progression.
I hope
and
she's not watching, by the way.
But I think we might just treat with RVD dose attenuated, but it doesn't mean you have to continue that triplet regimen forever. And I think you would dose attenuate that once you either get in our practice, we would dose attenuate that further by eliminating typically the parenteral drug because it can be difficult to come weekly, and then even drop the dex and even eventually maintain on a very low dose of len, approaching the first type of.
And would anybody, or maybe when you said about the patients, and a lot of them are out there in the community that can't drive into New York City or wherever, do you think Len-Dex is the right treatment for them, or do you think they should still be offered weekly subcutaneous bortezomib?
So, interesting
locally?
with the SWOG study, it's only 8 cycles of RVD they get. So we want to be clear that when they compare RVD to RD, it's actually 8 cycles of RVD, then they go on to Revlimid Dex. And so I think that's actually very helpful because you don't necessarily need to continue RVD indefinitely. So this trial very nicely shows that even with 8 cycles, you get a tremendous improvement in progression-free survival.
And I might be jumping the gun on this a bit, but lenalidomide, how long do you keep it going for? Is it indefinite, or do you stop?
So I think that if they're tolerating and clinically benefiting, then I think, and have a good quality of life, then I think it's reasonable to continue on.
Until progression, or do you do the
clinically
same?
beneficial.
Yes, we do. I would say in our view, the overwhelming evidence supports this, and we would refer from in the non-transplant population to the first trial, obviously, and then in the transplant-eligible population, obviously, we've got the Alliance CLGB 100-104 data that continues to look very promising.
That being, because most people won't know what that is.
Oh, it's a trial published by Dr. Phil McCarthy and colleagues in the New England Journal a few years ago, where we showed that lenalidomide until progression post-transplant resulted in not only a significant progression-free survival, but also an overall survival benefit.
And you both, so everybody says till progression, but in reality, if you're 5 years out, will you just keep going, or is progression, it continues, is indefinitely mean 3.5 years, or, when do you stop?
We stop at progression or toxicity.
So you would keep somebody on for 10 years if you had to?
We would.
That's what the data show.
Even if they're in
Every
complete
Len-based
remission?
study has been treated to progression, not a fixed duration. And I think the number of people that are getting out past 3 to 4 years are probably very small, unfortunately. And at that point, if somebody is lucky enough to have that durable remission, then you go back to the patient. It's a risk-benefit question again.
Well, but the median duration of response is over 40 months, so half the patients are getting out that far.
I agree.
It's not a small number.
It's
Are there any?
Ajay,
Are there? Are there any other?